Hi, my name is Ryan Gibson. I'm a second year internal medicine resident at Wellstar Kennestone, located in Marietta, Georgia. I'm presenting a case entitled Oncologic Emergency New Kid on the Block. This case deals with a newer immunocheckpoint inhibitor, ICI, that was deemed to have a relatively safe side effect profile, presenting an acute renal failure. So, quickly, a little background ICIs, immunocheckpoint inhibitors, um, they are a newer immunotherapy drug that are now used to treat a broad spectrum of cancers such as metastatic melanoma, non-small cell lung cancer, renal cell carcinoma. These immunotherapies work by blocking checkpoint proteins from binding to other partner proteins. This prevents the off signal from being sent, allowing T cells to kill cancer cells. Um, while these are relatively safe, some common side effects are rash, fatigue, and loss of appetite. However, immune related adverse effects have complicated the overall survival benefits in some cases. All right, quickly, let's go on to the case and we'll go from discussion from there. The patient is a 72-year-old female with a past medical history of small cell lung cancer, hypertension, AFib, who presented her oncologic clinic for her third round of chemotherapy and was found to have a creatinine of 17 and a BUN of 136. Her last creatinine 2 weeks prior was a 1.4. She was found to be anemic. Urinalysis showed 3 plus blood, 3 plus protein, and elevated RBC. She was immediately admitted to the hospital for further eval. She complained of decreased appetite and anorexia for 1 week, nausea and vomiting for the past 3 days, and associated metallic taste. She reported normal urine output, but had noted some foam with urination. She denied NSAID use. She had a remote history of nephrolithiasis that resolved without intervention. Her medications were reviewed, and with regards to her chemotherapy, she had received 2 cycles of chemotherapy. The first cycle with carboplatin that she tolerated well with no adverse effects. On her second cycle, she received the same chemotherapy and an immunotherapy was added, Tecentriq or eculizumab. Her second cycle was completed 10 days prior to her presentation. She was later admitted and seen by nephrology, who had a vas cath placed. She underwent emergent hemodialysis. After 1 hemodialysis treatment, her creatinine decreased from 17 to 9. There were no signs of any further renal recovery at that time. She underwent a renal ultrasound showing echogenic kidneys, but no nephrolithiasis, which is shown in Figure 4. She was started on IV steroids for possible immunotherapy-mediated renal failure with little improvement. She later received 3 additional hemodialysis treatments, which improved her creatinine to 2, which is close to her baseline. The patient declined renal biopsy. Her urine output remained normal throughout her hospitalization, and she was discharged to home on hemodialysis as an outpatient with follow-up with nephrology and her oncologist. So a little bit more on Tecentriq. This is a checkpoint inhibitor. These checkpoints are a normal part of the immune system and keep immune response from being too strong. By blocking them, these drugs are allowed cells to respond more strongly to cancer cells, and these immunotherapies have been approved to cover a wide range of cancers. Specifically, Tecentriq is a PD-L1 inhibitor, and its toxicity profile has been very favorable. Again, talking about mostly rash, fatigue, and loss of appetite. Some of its counterparts have been shown to show AKI, with some being as high as 2%, but it was very rare in this specific medication. While there's no clear cause identified, but some theories suggest that autoantibodies against the tissue or certain tissues that may normally express certain checkpoint receptors that then bind to anti-checkpoint inhibitor antibodies trigger an immune reaction against that tissue. Our patient presented with an emergent situation where she had to undergo immediate hemodialysis. Early diagnosis and awareness of the variability in immune-related adverse effects was the key to the treatment. This case demonstrates a cancer treatment causing acute renal failure after 1 cycle of treatment, which has been rarely reported. So quickly, some takeaway points are that this case demonstrates, the importance of medication reconciliation and also the timing of when new medications were started, and also understanding ICIs and just their most common side effects. While they might be relatively benign, you must keep an eye on more severe presentations. There's been documented hepatitis, myocarditis, and also CNS issues. So that's my case. Thank you for your attention and your time. Have a nice day.